Hello, everyone. This is Dr. Mickey again for this is the last chapter, which is chapter 45, which is a drugs for diabetes mellitus. So we'll start with the pathophysiology. And the disease also, and I mean, the management from the adult health or mid-surge perspective will be covered in adult health too of the spring semester of the junior year. So we just covered the previous chapter, the endocrine glands, and we went over the different types of glands that produce different hormones. And we said that, the P gland, pituitary gland, the anterior lobe would affect the pancreas, and the in which that the pancreas is part of the endocrine system. And the pancreas, by the way, is the only gland that is which produces both exocrine and endocrine, or it's the only gland that is called, you can consider it as an endocrine and as an endocrine. Exocrine gland because it produces lipase and amylase enzymes, exocrine glands, and endocrine glands because it produces hormones such as insulin. In addition also to the glucagon. So it produces insulin and glucagon as an endocrine gland. Insulin released when blood glucose increases, and then glucagon released when blood glucose decreases. So both hormones and drugs and medications, when we cover and go over the medications, for diabetes. So hormones and drugs or medications can affect blood sugar hyperglycemic or hypoglycemic effect. So they are all going either to increase or decrease the blood sugar level. So we have different types of cells in the pancreas. We have the alpha cells and the beta cells. The alpha cells, they produce the glucagon, and the beta cells, or the beta cells, the cells of Langerhans, or what's called the islets or islets of Langerhans in the pancreas. They are the either alpha or beta. Alpha produce the glucagon, and beta produce the insulin. So alpha glucagon, beta insulin. So we have a normal blood level here, 70 up to 100 milligrams per dl. That's normal blood glucose level. When there is a high blood glucose level, hyperglycemia, the pancreas is going to secrete the insulin, and then which is going to make the cells take up the glucose for energy and storage. In other words, that this insulin hormone will allow the glucose molecules to enter the cells for metabolism as a source of energy and storage. And that will eventually is going to result in the homeostasis to control the blood glucose level within range 70 up to 100. The opposite here, when there is a hypoglycemia, low blood glucose level, then the pancreas will secrete the glucagon hormone, which is going to affect the liver to break down the glycogen, because the liver has lots of storage of glycogen storage molecules. Or these glycogen molecules are stored in the liver in case of hypoglycemia. So this glucagon will stimulate the liver to break down these glycogen molecules, and it will release. So converting the glycogen into glucose, which will enter the bloodstream and will result in homeostasis, also is going to be restored. So homeostasis is restored either in hyperglycemia by producing insulin or hypoglycemia by the pancreas producing glucagon. So within or by pancreatic ability of producing insulin and glucagon, we can control blood glucose level and keep it within range. Risk factors for diabetes, either type 1 or type 2. You see under type 1, you will find that there is genetic predisposition and environmental factors. Same thing under type 2 diabetes. There are genetic factors and environmental conditions or environmental factors. So the disease as known as a multi-system disease, which is diabetes mellitus here, in which that it's affects the insulin production. There's an abnormal insulin production problem in terms of the pancreas will be affected by the inability to produce sufficient amount of insulin, or sometimes there is a inability of the tissues and cells to utilize insulin, which is called impaired insulin utilization. Sometimes it's both. The problem is, combined, combining these two factors or two mechanisms, is that patient will develop the diabetes because of both insulin inability to produce enough insulin or nothing. In addition to that, also the cells inability of the cells to utilize insulin. Either one factor or both factors combined. The leading cause of heart disease, stroke, and adult blindness, and non-traumatic lower limb amputations is diabetes mellitus. So the DN diabetes, and here when I say diabetes means diabetes mellitus, it's not diabetes insipidus. So diabetes mellitus or diabetes here, it's the leading cause of heart disease, stroke, adult blindness, and non-traumatic lower limb amputations. And this will, I will say briefly, we will cover some of these long-term complications that are associated with diabetes mellitus. So in terms of risk factor etiology, we have a long list of etiological factor risk factors from previous slide. And here we can include genetic, autoimmune, especially with the autoimmune, that's type 1, and genetic also can be type 1 or type 2. But when we say autoimmune, it's most likely type 1. Viral infections, especially affecting the pancreas. Environmental factors like obesity, stress. There are certain medications also that may induce or may precipitate the diabetes incidence or onset. Meds which would increase the risk of diabetes mellitus includes steroids, corticosteroids like prednisone, or the corticosteroids across the board will lead to hyperglycemia. Steroids, thiazides, thiazide diuretic medications, phenytoin, dilantin, which is anti-epileptic medication, and the antipsychotic, but it's in what's called the atypical antipsychotic medications like clozapine, Clozaril. Brand name, generic name is a clozapine, which is Clozapine. 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 Clozapine, which is an atypical antipsychotic, also it's a drug that may lead to diabetes mellitus. And we know that the incidence of developing the diabetes mellitus from using or taking or administering these medications, usually it doesn't result in a short period of using, short-term use. Usually it's a long-term use. Months and years of use of these medications could result in a diabetes mellitus, except for the steroids. Steroids, instantly will lead to an increased glucose hyperglycemia would result from steroids, and that's explains why patients on steroids should be on slide scaling on the insulin coverage. So should be in slide scale coverage with insulin once we put them on steroids. But all these medications would lead to diabetes mellitus from long-term use. Either it's steroids, corticosteroids, prednisone, methylprednisone, sodium Cortef, thiazide, phenytoin dilantin, atypical antipsychotic like clozapine. All of these meds can lead to hyperglycemia. Now this slide, it's like provide like an analogy, the difference between diabetes type 1, diabetes type 2. Diabetes type 1, remember that the insulin responsible for the allowing the glucose molecule to enter the cell. So this is the receptor, the door in which that the insulin, the type 1, the key is lost. There is no key. In other words, that the door is locked and the glucose molecules will stay outside because there is no insulin at all. When there is some insulin, then the key slightly would open the door because there is some insulin with type 2. With type 2, there is some insulin. It's insufficient, but there is some insulin. Will allow the door to open slightly slit and then allow glucose molecules to enter, but will not be sufficient to allow for all glucose molecules to enter the cells. So that will leave the majority of the glucose molecules in the bloodstream, which is hyperglycemia. So in type 1, if that's the receptor, which is the insulin molecule, that type 1, the key is lost, then all glucose molecules will be in the bloodstream. And type 2, in which that the door is slightly open because we have some insulin molecules, so that will result in some insulin glucose molecules, some glucose molecules will enter the cells, and the majority of them will stay in the bloodstream. And that's the just analogy between type 1 and type 2. The normal insulin metabolism. Now, the increased insulin after a meal, it would stimulate the storage of glucose as glycogen, which is called glycogenesis. So that will increase protein and lipid or fat synthesis. Also the insulin. So the insulin does, it has multiple functions, not just it will stimulate the storage of glucose as glycogen, but also it will inhibit the tissue breakdown by inhibiting glycogenolysis, gluconeogenesis, and ketogenesis. So the insulin will inhibit the glycogenolysis, which is glycogen breakdown into glucose. It will prevent that. So glycogen will stay in the liver stored as glycogen. It will prevent also the gluconeogenesis, which is the conversion of protein to glucose. And that would only happen or take place during the starvation. Patient will start using the stored, or what is the storage of glucose storage or protein storage from the most of the protein stored either in the liver or in the muscles. Ketogenesis, that's which is the conversion of the fat into acid, and that's when in the absence of insulin, that's when the body lean to, to use the fat molecules or cells as the source of energy, and then the patient will have will have fatty acids, and we have ketones. That's so the insulin would prevent that ketogenesis, conversion of the fat into acid as a source of energy. But in the absence of insulin, patients may develop DKA, diabetes ketoacidosis. Diabetes ketoacidosis, that's when the body leans towards the fat molecules as a source of energy, because there is no insulin. There's no way you can benefit from the glucose molecules. There is no insulin. So they have to find a way to generate energy, and that will be the fat molecules. So that in the absence of insulin, ketogenesis would take place. So insulin would prevent all of these things. Just like genolysis, we have more storage of glucose as in glycogen in the liver, will prevent the gluconeogenesis, conversion of the protein into glucose, and the conversion of fat acid, of the fat into acid, which is ketogenesis. So all of these are functions of the insulin. So the insulin has multiple functions, and will also enhance fat deposition in adipose tissue. Now, the hormones that will regulate the insulin, like they work opposite to the insulin function. They're called counter-regulatory hormones, like glucagon, epinephrine, growth hormone, cortisol. So anytime we would say glucagon, it will result in increased glucose. Epinephrine will increase glucose. Growth hormone, cortisol, all of these hormones are going to lead to hyperglycemia. Increased glucagon lead to hyperglycemia. Increased epinephrine, increased hyperglycemia. Increased growth hormone would lead to the hyperglycemia. Increased cortisol will lead to hyperglycemia. All these hormones work opposite to the insulin hormone. From previous slide here, in this figure, you'll find out the insulin secretion is usually takes place right after ingestion of the food. So right after the climax or the highest secretion level of insulin secretion will be right after the breakfast, after lunch, after dinner. So it's kind of timed with food ingestion. So type 1 versus type 2. Type 1 formerly known as a juvenile onset or insulin-dependent diabetes. So the type 1 most often occurs in people under 30 years of age. The most common type is called type 1A. Type 1A, like about 80 to 90% of the cases of this type of type 1A. Now, this disease would result from the progressive destruction of the pancreatic B or beta cells, which produces the insulin. It's an autoimmune, believed to be an autoimmune disease, in which that the autoantibodies will cause a reduction of about 80 to 90% of normal beta cells function before manifestations occur. So it's an antibodies, it's an autoimmune disease in which the autoantibodies would lead to a reduction of about 80 to 90% of the normal beta cells in the pancreas it will reduce their function by about 80 to 90% of the beta cell function. And that would even be present or before or occur before any manifestations would be actually present. The causes of the type 1 would be most likely genetic predisposition related to human leukocyte antigen, which was identified and located on chromosome number 6, and exposure to viruses. Different viruses like mumps, congenital rubella, they would or may trigger the autoimmune destruction of the pancreatic beta cells. So type 2 diabetes, which accounts for the majority of the cases of patients with diabetes mellitus, which is about 90% of patients, they develop type 2, and about 10% only type 1. So the onset of the disease process, usually it's a gradual onset, and in which the pancreas continues to produce some endogenous insulin, but the insulin produced from the pancreas is insufficient, inadequate, or poorly utilized by the tissues. So it's either that the amount of insulin is insufficient to the amount of glucose are available in the bloodstream, or the tissues are unable to utilize or the poorly utilizing or cannot use the insulin. So type 2, as we said, it's either metabolic, genetic, or environmental in terms of the etiology. There are three main metabolic abnormalities that may result in diabetes type 2: insulin resistance, IGT or impaired glucose tolerance, or inappropriate glucose production by the liver, which will result in inadequate, insufficient amount production of the liver of the insulin by the liver. So, sorry, it's the inadequate, inappropriate glucose production by the liver. That's sorry, that has nothing to do with the insulin itself. But we said that most of the type 2 diabetes usually develop that from the decreased significant decline of the pancreas secretion of insulin. But when it comes to metabolic abnormality, has to do with the liver, that's from the inappropriate glucose production by the liver. The other types of, before we get to the other types of diabetes mellitus, just briefly talking about the insulin resistance and IGT and inadequate glucose production by the liver. The insulin resistance, the body tissues, they do not respond to the insulin. The receptors are either unresponsive or insufficient. There are insufficient number of receptors to respond to the insulin. The IGT, the impaired glucose tolerance, would result or occur when the alteration in the beta cell function is mild. Blood glucose levels are higher than normal, but not high enough for a diagnosis of diabetes. That's called impaired glucose tolerance. Impaired glucose tolerance is either due to decreased secretion of insulin or due to the enhanced hepatic glucose output, which is, in other words, we call that as pre-diabetes. There are other types of diabetes mellitus, gestational diabetes, for example. develops during pregnancy, detected usually at 24 to 28 weeks of gestation. There's a high risk of cesarean delivery, perinatal death, and neonatal complications. So the gestational diabetes is a form of glucose intolerance diagnosed with or during the pregnancy. Now, the gestational diabetes occurs most frequently among African Americans, Hispanics, Native Americans. Other risk factors include obesity and family history of diabetes mellitus. During pregnancy, gestational diabetes requires treatment, usually lifestyle changes, insulin plus insulin, to normalize the maternal blood glucose levels to avoid fetal complications. Immediately after pregnancy, 5 to 10% of women with gestational diabetes are diagnosed with diabetes mellitus, usually type 2. Women who have had gestational diabetes mellitus have a 40 to up to 60% chance of developing diabetes mellitus within 5 to 10 years. Secondary diabetes, which is the type of diabetes mellitus that would result from another medical condition or due to the treatment of medical condition that causes abnormal blood glucose levels, like patients with Cushing syndrome when they have high steroid production, adrenal gland producing too much of steroid, cortisone, Cushing syndrome, hyperthyroidism, increased production of thyroid hormones T3 and T4, parenteral nutrition, patients on a TPN, especially total parenteral nutrition, they are at risk for also secondary diabetes. So these are the three main conditions that can be considered as the causative results or factors for the secondary diabetes. Just to highlight something before we move on to the clinical manifestations of type 1 and type 2, there's something called metabolic syndrome. Metabolic syndrome, which is a cluster of risk factors that occur together. So we have 4 different things that are going to be highlighting or diagnosing patients with metabolic syndrome. Metabolic syndrome would include hyperglycemia, high blood pressure, hypercholesterol or hypercholesterolemia, and increased waist circumference. So 4 main conditions added together at the same time would diagnose patient with metabolic syndrome: hyperglycemia, hypertension, hypercholesterolemia, and increased waist circumference. So metabolic syndrome, it's not a form of diabetes mellitus, but it is related to diabetes mellitus because metabolic syndrome increases the risk of cardiovascular disease, increase the risk of diabetes mellitus, increase the risk for stroke. So the diagnostic criteria for metabolic syndrome include the presence of 3 or more of those risk factors that we had just included or indicated a few seconds ago. So type 1 versus type 2 diabetes, these are the clinical manifestations of each, in which sometimes it's very difficult to differentiate between type 1 and type 2 because they're very similar. And when it comes also to the another slide with differentiate between type 1 and type 2 diagnoses, we start with the hemoglobin A1C test, glucosylated hemoglobin, which is hemoglobin A1C test, which determines the glycemic level over time, because we know that the glucose remains attached to the hemoglobin molecules over 120 days. So the normal value is 4 to 6%. The goal in patients with diabetes mellitus is 7% or less. Diagnostic for diabetes mellitus will be itch, hemoglobin A1C over or equal or higher than 6.5%. At risk for diabetes mellitus would be hemoglobin A1C 5.7 up to 6.4%. Criteria number 2, which is a fasting blood sugars, which is defined as no calorie or caloric intake for at least 8 hours. And we measure the blood glucose levels, and we say when the fasting glucose blood level is equal or higher than 126, that is diagnostic for the diabetes, and it at risk for diabetes when the fasting blood glucose test when it's 110 up to 125. Another line or criteria for diagnosing the diabetes mellitus is the random, which is plasma glucose measurement of either equal or higher than 200. It would be diagnostic for diabetes, which is usually when we say random, which is 2 hours of the oral glucose tolerance test over 200. And that's when we use a glucose load of 75 grams. So the patient would take glucose 75 grams in the form of tablet, and then the 2 hours later when we measure the glucose level in the blood, we will find when it's higher than 200, that's diagnostic, and when it's 140 up to 199, that's when we will see the patient at risk for diabetes. So higher than 200, diagnostic, at risk when it's 140 up to 199. And treatment, we will cover the dietary restrictions, exercise, and other modalities like lifestyle changes. All of that will be covered in the mid-surge adult health course, the second one in the spring. And we will just focus on the drugs, medications, and the different types of insulin for the diabetes mellitus. So insulin, the prototype drug for insulin, which is a humalog or human regular insulin, humalog or humalin, Novolin or Novolog. So that would be the R, which usually ends with R, means regular insulin. And the duration, we'll talk about the onset, when the onset, the duration of action, that would be covered in one of the slides comparing between all different types of insulins altogether. So for example, here we have different types of insulin. We have rapid acting like Lispro, short acting like regular, which is Humulin or Humalin R or Novolin R, so these are regular insulin that ends with R. The intermediate acting, which is like the insulin which ends with N, like Humulin N, Novolin N, that's NPH. That's intermediate acting, NPH or lente. And then we have long acting, which is the ultra lente, which is like Lantus, Ditamir, Glargine, Levemir, all these are, or Lantus, all of these are long-acting medications, insulins. So the rapid-acting insulin, like Lispro, the onset usually it's within 15 minutes. The time in terms to peak would be 60 to 90 minutes. Duration 3 to 4 hours. Short acting, the onset 30 minutes up to 1 hour. Peak 2 to 3 hours, duration 3 to 6 hours. Intermediate like NPH would be onset 2 to 4 hours, peak 4 to 10 hours, duration up to 16 hours. However, the long-acting, it will work over 24 hours. Onset 1 to 2 hours, but will have effect over 24 hours. Now, this slide provides not just the administration and timing, but also the compatibility. So, for example, the insulin Espar, which is rapid, the onset 10 to 20 minutes, even with the rapid, different type of insulin, we'll find some tiny or minor differences among these medications, even though they are listed as rapid. Like the top, the upper or the top three medications, either it's the insulin Aspar or Lispro or the Glycine, they're all rapid. But the first one, which is the insulin Aspar, the onset is 10 to 20 minutes. The second one is 15 to 30, and then the third one is the same thing. But again, these are just the tiny or minor kind of change differences among the. But when we see rapid um, uh, acting insulin, we know that the onset is within like 15 minutes. It will peak within like an hour or 1 hour 30 minutes, and it will be good for up to 4 hours. That's the rapid acting. The duration, it doesn't last longer than 4 hours, 3 to 4 hours. So there's again, some, on minor, like, differences, according to the type of the manufacturer, the medication type. But, when we say rapid insulin, the duration about 3 to 4 hours, go max of 5 hours, probably, like, according to this slide. Now with the insulin R, which is a short acting, the onset is like 30 minutes up to 1 hour, and then the peak 2 to 3 or 4 hours, and the duration is for 3 to 6 hours, and it goes, it may go up to 8 hours. But all these medications are going to be sub-Q. You can give the insulin, regular insulin is the IV. You can see that, all of them sub-Q except for regular insulin, Humulin R, Novolog R can be given IV. The rest of the medications, NPH or long-acting like Levemir, Ditamir, Glargine, all of these medications, intermediate like NPH, and then the long-acting like Levemir and Lanta, all of these should be given only subcutaneous. So then all these insulins, all different types of insulin given sub-Q, except for the regular insulin, Novolog R, Humulin R, Novolin R can be given sub-Q and as an IV as well. So the rapid acting, just one of the educational tips and also for nursing implications for rapid acting versus short acting. The rapid acting synthetic insulin analogs, rapid acting insulin like Lispro, Aspar, Apidra, the onset of action approximately about 50 minutes. That's why the rapid acting insulin, if that's Lispro, Aspar, or Apidra, should be injected 10 or within within 15 minutes, 0 to 15 minutes before the meal, because the rapid acting analog or insulin most closely mimic the natural insulin secretion in response to a meal. However, the short-acting regular insulin short-acting, the onset of action is about 30 to 60 minutes. So the drug should be, the short acting should be injected 30 minutes up to 45 minutes before a meal to ensure that the onset of action coincide with meal absorption. So because the timing an injection 30 to 45 minutes before the meal is difficult for people to incorporate into their lifestyle, the rapid acting insulin are often preferred by people who take insulin with meals. The rapid acting are more preferred because of this reason. So the administration of insulin. So it cannot be given orally, even there is, regardless in disregarded of the cutting edge and new research studies and no medications, but in general, it cannot be given orally because the insulin is will be inactivated by the gastric secretions. Only regular insulin can be given IV. Problems with insulin therapy, hypoglycemia as major side effect. When you give insulin, patient may become hypoglycemic. Allergic reactions, lipodystrophy, which is a hypertrophy of the subcutaneous tissues, lumps and dents in the skin from repeated injections. That's why we have to use the site for 6 to 8 injections and rotate the site. These are the sites from adult health 1 for the subcu injections. Now, for the management of type 2 diabetes, other than the insulin, we have, and we'll go to the class of hypoglycemic agents in a minute, that the treatment goals for people with type 2 diabetes, prebrandial blood sugar below 110. Prebrandial means meals, so pre-meals, prebrandial. And then the hemoglobin A1C of 6.5% or less. Now, the classes of oral hypoglycemic agents or medications that are listed here on this slide: sulfonylureas, meglitinides, biguanide, and glucinide or alpha glucidase inhibitors, thiazolidinoids, and the DPP-4 classification. And we have example or a few examples of medications for each group or classification, and we have the mechanism of action for each one as well. This is the list of medications in which we have combined drugs, more than one medication. We have 2 medications in one tablet. So sulfonylureas, for example. Sulfonylureas, they stimulate release of insulin from pancreatic cells, from pancreas. They increase the tissue sensitivity to the insulin receptors. So the cells or the target cells the drug will increase their sensitivity to the insulin and will accept the insulin at the receptor. Hypoglycemia is a side effect. So usually the hypoglycemia caused by taking too much medication or not eating enough food. So the sulfonylurea medication will do both of these things. In other words, that it will result in hypoglycemia and increase weight. So the side effect of sulfonylureas, hypoglycemia, and weight gain. The biguanides, most side effects are minor, um, um, but they are more of GI related, more GI symptoms. And biguanides like metformin, glucophage, the most commonly prescribed medication among all of the hypoglycemic agents is metformin glucophage. Lactic acidosis is one of the common side effects of glucophage. So that explains why we have to stop the metformin glucophage before the use of a contrast media. Anytime we have to use a contrast media, we have to stop the metformin glucophage. Metformin or glucophage is the best initial therapy for obesity-related type 2 diabetes because the metformin will not cause hypoglycemia and it will not increase weight. So weight gain and hypoglycemia as a side effect of sulfonylureas can be avoided with the use of biguanides like metformin glucophage. So biguanides like glucophage do not use in patients with kidney disease, with liver disease, or heart failure. Do not use in people who drink excessive amounts of alcohol. Metformin, IV contrast media that contain iodine will cause a risk of acute renal injury or failure, which could exacerbate metformin-induced lactic acidosis. That's why we have to stop metformin glucophage few days before the scheduled diagnostic testing in which that they anticipate to or expect to use IV contrast media with iodine. So we have to discontinue metformin, I would say a day or two before the procedure, and maybe resumed 48 hours after procedure, assuming kidney function is normal. So we have to do a kidney function test to make sure that it's within range so we can resume metformin glucophage. Thia- Thiazolidinoids, like the Avandia or glitazones, or they increase the risk of myocardial infarction and stroke. So we should avoid the thiazolidinoids like Avandia or glitazone. We should avoid that in patients with heart failure. So the drug increased peripheral insulin sensitivity, so contraindicated in patients with CHF and fluid overload. The glitinides, the most common side effect is hypoglycemia. meglitinides, such as Starlix or Prandin. The acute complications from the diabetes mellitus, acute complications and long-term or chronic complications. The acute ones are hypoglycemia or hyperglycemia, and we will go over the DKE and HHNKS, which is hyperosmolar hyperglycemic non-ketotic syndrome. We will go in depth about the signs and symptoms and management in adult health too. And the significant difference between DKA and HHNKS is that both cases, DKA tend to develop or result in type 1 diabetes or patients with type 1, and the NKS or the NK usually from in patients with type 2 diabetes. Both cases will be presented with severe dehydration, more in HNKS than DKA. The dehydration will be more severe in patients with HHNKS than in patients with DKA, but both will be dehydrated. And I listed here the difference in this slide in terms of the assessment findings, treatment modalities, even for each type, complications. Patients will have angiopathy, which is, in other words, that there is either macro or microvascular conditions that will result from diabetes mellitus. And this usually results or develop over time, over the years, and in terms of changes at the vascular level and different organs, and the heart, and the blood vessels, in the brain, and the kidneys, and like coronary artery disease, CVA, peripheral vascular disease. These are macrovascular conditions that may result from as a long-term complications from diabetes mellitus. For microvascular, that's the first one, retinopathy. So as we said, that one of the prevalence, high prevalence of blindness, adult blindness, that's from diabetes. And that's because of the effect on the retina and the bleeding, blood vessels rupture, and the bleeding in the retina, and the resultant blindness from that explains why patients with diabetes mellitus, they have to go for annual or sometimes twice a year of retina or eye exam. Nephropathy, kidney also may deteriorate in terms of vasculature, and then eventually the kidney function would decrease and result in kidney failure. Neuropathy, skin tissue problems, infections, and so forth. And sort of changes in terms of in the retina, and the kidneys, and the skin. And in terms of the skin changes that and the vascular affecting the skin, and which would result in a necrosis, and eventually the ultimate or the only treatment modality would be the amputation of the limb.